Marie Peppers, as she said, LPN. I have been an LPN about 37, well, almost 37 years. I went to an old-fashioned school of nursing in Boston. And that's when you'd be in the classroom for 1 week, just learning a little bit. And then they threw us all into the hospital. So I had just hands-on the whole year. The LPN program back then was 1 year, all hands-on. It went through the whole year, no summers off, nothing like that. So I did that. And, flash forward all these years later, I've done a little of everything. And what I want to say to the nurses, LPNs, RNs, nurse practitioners, nursing students, is that as an LPN or as a nurse, I use the proximity principle to work my way into different areas and work my way up to what I'm doing now. And I didn't know that was a principle. The proximity principle is when you want a job or you want to get into different areas, you need to proximate yourself or associate yourself with other people that have the similar interests as you, or that are in the area that you might want to get into. So even when I was a brand new LPN, I really wanted to get into pediatrics, med-surg pediatrics. I was in med-surg. Well, there was no such thing really as LPNs being in Massachusetts, being in pediatrics med-surg. So I used to, on my lunch hour, always go over to the peds unit and kind of hang around and, just talk to the nurses. That's proximity principle. LPNs normally don't get into those certain sections. I wanted that. So eventually, because of the relationships that I made, I was able to get into that area and many other things that I've done as a LPN. That's one of the big things I want to say is that if you try to surround yourself with people that inspire you, that you connect to them, LinkedIn is an amazing place to connect to. So throughout my years, I've done all kinds of different things as an LPN. Never wanted to be an RN. I thought about it a few times, but I was happy with what I was doing as an LPN. And I even got into some case management, home health. I worked with the visiting nurses. I mean, I actually did home health where I was seeing the patients, doing wound care and various things, visiting one patient to the next. I was doing home health on the weekends, hospice. I even did some supervisory work as an LPN. Of course, there was always an RN, over me. Anyway, fast forward to now, I am still an LPN, and prior to COVID, about 3 years prior to COVID, I got into a lucky opportunity. It was a doctor that wanted to start the remote nursing program for his patients.
I just wanted to say thank you for bringing up the history of nursing and the strong role of LPNs, and that you're happy in your current role and you never wanted to pivot to another role. I think that there's so much importance in being happy where you are with your current credentials.
Yeah, well, I have said, to some of the RNs that were my charge nurses, I have said, I'm happy as an LPN and I don't want to be a charge nurse because I don't want to be responsible for anyone else but myself. My patients, of course, when I'm on med surg or wherever I was always under the direction of an RN or a doctor. But, when I'm the LPN and I'm not charge nurse or anything like that, I'm responsible for myself, my patients. And I really enjoyed that, enjoyed not being responsible for other nurses and then their patients. And so especially many times RNs are, responsible for everybody. So that's one of the reasons why I just really loved my role in what I was doing. And I just didn't want to ever get into any of the supervisory stuff. But anyway, yes, I was at the hospital and nurses are always looking around to see what's out there, what's better, I really love my hospital job, but we are always looking to see, okay, so who's doing what and what's what. And it wasn't like I was ever in my whole life. I was never like I was always looking for money, money, money. I was looking for opportunity and what's different. And just like I said, taking your interests and then attaching them and associating yourself with other people, getting to know people, rooting them along the way, becoming friendly with them, whether it be on Facebook or on LinkedIn. I recommend LinkedIn because it's really a good place for nurses, especially if you want to, go further in your career. LinkedIn's definitely the place to be. So long story short, I did take on a part-time position for a doctor that was starting the Medicare Case Care Manager program that came out in 2015. This was 2017 that I took this position, and he handed me the software for the remote patient monitoring and transitional care. And then he handed me the Athena healthcare software, and he just handed me this computer software and said, learn it. And Athena had a little bit of educational programs on their system. So I learned the Athena computer system. I'm not a computer person. And then I learned the Thorough Care system. The president of Thorough Care back then had no real training for what he was teaching me. And so he taught me himself. So I enjoyed my job. I worked from home. I was doing kind of care case management from home. So in between the visit with the patient at the doctor's office, and then the patient goes home, all those things that kind of fall through, all of a sudden they're not picking up their medicine. Oh, the MRI that was ordered didn't happen. Oh, the patient didn't have transportation to X, Y, and Z. So my job was care coordination, care management, taking care of those gaps. SDOH, if you don't know what SDOH is, you got to know it. SDOH is social determinants of health. It is the key word, SDOH, the key word for 2024 and into 2025. But nurses have done SDOH forever. SDOH is making sure your patient could pick up their medicine or it's delivered, making sure that does your patient have food? Do they have a roof over their head? Do they have, are they seeing the other doctors that they were supposed to see, transportation, just the basics, social determinants of health. So I did a little of all that, enjoyed it. Long story short, the nurses at the hospital begged me to write a program on how they could do remote nursing. And I said, well, I don't want to do that. I don't want to write a program. I don't do that kind of stuff. And they said, please. So for 6 months on and off, they begged me. They said they wanted to do what I did. And this was, so new back then. Anyway, I wrote the program and eventually they came. And that was my first course. And then I've written many other programs since then. So I know I could talk for hours. So I know we want to condense all this.
No, I love that. I love that. I think it's so important for nurses who are still at the bedside to see how someone who has successfully transitioned away from the bedside has created that like hopscotch effect. So thank you for sharing.
Yeah, I had no intention of ever really leaving it because I really liked my patients. I liked working with. Sometimes it was hard at the hospital or in the nursing homes or in home health. Sometimes you have too many patients or something's going on. But the majority of the time, I did really enjoy being a nurse. I enjoyed my patients. Most of the time, I enjoyed the other nurses I worked with. Of course, there's always going to be a few that you don't like. And you got to try to get along. And there's always going to be a few that are cutthroat. And as you get older, you eventually learn to let some of that stuff just kind of roll off your shoulders. It's not easy working with I used to say a whole bunch of hens, ladies. And of course, we have gentlemen that work with us too. Many of us nurses really enjoy when there's a male nurse on the floor. It kind of breaks up everybody. So, the majority of my time I enjoyed being a bedside nurse or home health nurse or whatever. This was a kind of a fluke. And I all of a sudden realized that I could still be a nurse and enjoy it and not touch the patients or even see them. Now, some remote nurses see the patients on the video, but I was just doing telephone. And I realized, wow, it's a whole new nursing skill to be able to help a person when you cannot touch them. You cannot really see them. You cannot smell them. Nurses use a sense of smell, even though we don't particularly want to smell the bad smells. You can smell gangrene before you walk into that room of the patient's room. Diabetic, you can smell the diabetic sweetness sometimes down the hallway. So we use our eyes, we listen, so, on video or on the phone, it's a little bit different, but I realized, hey, I really like this. Eventually I have a lot of my nurses. I have almost 11,000 that have gone through my courses in the past 5 years. Nurse practitioners, doctor, nurse practitioner, a few doctors, MSNs, BSNs, ASNs, diploma RNs, and LPNs and LVNs. So a variety of everyone. Do have a lot of nurse practitioners that are a little bit burnt out from being nurse practitioners, and they want to now work as RNs again remotely. Some of them will work remotely as an NP, but a lot of them want to do utilization review or care or case management remotely and use their RN again and not their NP. And so I have people coming to me like that. They're working as an NP, maybe in primary care or family practice. They're seeing way too many patients per day. And after X amount of years, they're like, maybe I'll go use my RN license and take utilization review from Marie. So I teach utilization review also. We teach, we have a diabetes course, diabetes health coaching.
So let's talk about your first, one of your first courses that I have here, utilization review. Can you talk a little bit more about what utilization review is? What might a typical day look like? And what are some tasks a nurse might do?
Utilization review and utilization management. They're nurses that usually work behind the scenes. They could be case managers where they're doing a lot of the case management, such as talking to the patients in between from the doctor's office, or talking to patients that have been injured, those kind of things. Talking to patients that are being discharged from the hospital, but also utilization review people. They work behind the scenes to determine or help to determine, who needs a certain surgery. Well, the doctor determines you need the surgery, but then the utilization review or risk management person gets a bunch of cases together, and they get case files. And they have to look at these files. There might be 18 a day that they have to go through, and they have to make determinations on, does this person, like, say they need a certain drug, a special, high-tech IV drug, or maybe they need a knee surgery, or, whatever it may be. Is it a pre-authorization? Is it a pre-certification? What is this? So they have to look at the case. They have to determine if the case, I got a couple little notes here. They have to determine the risk of the case. They have to go into either the pre-certification, the authorizations, they have 24 hours to sometimes a 14-day turnaround for these types of cases that they have to look at. So many times you might only have a 24-hour turnaround. Other times you might have a case where you're working on it. You go back and forth with the doctor or the office, trying to get more information to determine, does this person's policy show that they have such and such available to them? So it's not always just, do they need this medicine, but does the policy cover it? And then you have to look to see if all the determinations are made in regards to, basic medical care. If someone is in a certain situation, do they need X, Y, and Z? Do they require the knee surgery inpatient, overnight? Can they do outpatient? Has the physician done X, Y, and Z to determine that, yes, now we're ready, for this type of surgery or this type of medication or procedure? So that's what a utilization review nurse does. They work behind the scenes But some of them can also work with the patients. It depends. There's so many different areas. There's concurrent review, there's retrospective review, there's prior authorizations, there's pre-certifications. I mean, there's just a huge, huge area. So nurses will say to me, I want a job where I don't have to speak to anybody. And I'm like, well, utilization review, sometimes you might not speak to anyone. Other times you might speak 50% of the day to the doctor's offices and 50% behind the scenes. It depends on what kind of utilization review they get into. So, I mean, I could go on and on about utilization review, but it's basically not talking much to the patients, working behind the scenes.
So are there certain specialties that are best suited for utilization review?
Not really. Everybody needs risk management and utilization review. Every specialty and non-specialty. Now, the specialties that pay the most, which is shocking, but like I can take an LPN that's done, home health, or they've done long-term care, rehabilitation, maybe doctor's office or hospital. RN, they could be an OR nurse, they could be med surg, they could be home health, they could be long-term care, I mean, whatever. But the specialties that are in the most demand, psych and behavioral health for utilization review, and they pay the most. And that is because not enough psych and behavioral health nurses want to work behind the scenes doing utilization review. Because if you get into psych and behavioral health, you're going to be a talker. You're going to be with your patients. So I have a lot of psych and behavioral health nurses that love taking the utilization review course from me. They learn the basics, and many companies will say they want 1 year or 2 years experience in utilization review, but with my course, they usually count it as towards 1 year experience already taking my course. A lot of companies. And then there's other companies that might say they prefer you have utilization review experience, but they don't require it. The other specialty that we don't get enough of is oncology nurses. We just don't. I mean, there's so much utilization review for oncology nurses, transplant nurses, and the kidney transplant or like bone marrow transplant, people like that, transplant nurses. Now, many times people that are operating room nurses come to me and they take my courses and they get a job in utilization review when their whole career was operating room, or OR circulating, and we can get them and help them to get into different types of utilization review or case management. Our OB nurses, I have lots of OB and NICU that come to me, and I'll say, look, I can help you, but you are in a very specialized area of maternal health and OB. So about maybe 30% of the jobs will accept you, either for OB and ICU, or they might train you in, like we teach a lot of medical, surgical, and orthopedic utilization review. So they might actually put you in that area since you had some of that training, even though you're OB. So I mean, we can help almost anyone get into this, but